Welcome and good evening, everyone, to the special webinar event tonight. Thank you for joining us. On behalf of the SAB, we want to thank GE HealthCare for being 2025 sponsors and supporting this webinar event. Before we begin, just a few reminders to anyone new to the SAB webinars. If you have any questions throughout the presentation for our speakers, we do encourage you to submit them. You may do so by using your control panel. There's a question feature located there. We'll answer all the questions at the end of the talk during the Q&A. At this time, I'll hand it over to Dr. Pepper and he will get us started. Thanks for joining.
So a very warm welcome to everyone to this Society of Advanced Bronchoscopy webinar, very graciously hosted by GE HealthCare. Today's topic is the impact of patient care using mobile cone beam CT-based augmented fluoroscopy with robotic bronchoscopy. My name is Dominique Pepper. I'm in the Pacific Northwest, and I'm with Dr. Peter Lee.
Hey, good afternoon, everybody. Well, good evening in the East Coast. My name is Peter Lee. I'm an interventional pulmonologist here at OHSU, also from the Pacific Northwest. I'm the medical director of IP here, along with the lung nodule program, and I'm very, very happy to be part of this.
Great to have you here, Peter. While we have the disclosure slide up, just give you the format for this presentation. We'll have a 20 to 25-minute presentation on our experience using the technology. We'll then transition to a Q&A where I'll interview Dr. Peter Lee, and then we'll open it up to everyone to ask questions. So we're going to start this presentation with Lewis, who was middle-aged, presented to our clinic with a 9mm lung nodule, spiculated in nature, and to all intents and purposes, this would be stage 1A1 lung cancer. If he had had a biopsy, if we had confirmed lung cancer, and if it had been resected, he would have had a 5-year survival of 92%. But that isn't the story that we're telling today, because the pulmonologist who was taking care of him felt that it was a bit tricky. Let's get another scan in 2 or 3 months and see if it's enlarging. And with Thanksgiving coming along, the follow-up scan was actually done 4 months later and showed that the nodule measured 34mm. One of the hylar nodes were involved. And if he had had a biopsy at this time, he would have had stage 2B, 3A lung cancer with a 50% chance of being alive in 5 years. However, this was around Thanksgiving and scheduling was a bit tricky. And he ended up only getting his biopsy done 5 months after the initial scan. And at that time, he came in with the pleuritic chest pain, had a pleural effusion, was diagnosed with lung cancer, and unfortunately died 2 months later. And obviously, this exposed a serious flaw in our ability to diagnose early lung cancer, but also in terms of our programmatic setup to expedite the diagnosis or treatment of patients with lung cancer. What really scared us about this case was that if we went back in time, that lung nodule was there a year prior, measuring 7mm with a slightly spiculated appearance, and even a year before that, measuring 5mm. And unfortunately, this is what's happening every single day in the United States, patients with lung nodules that are slowly growing and ultimately progressing to stage 3 and stage 4 lung cancer. This audience knows that stage 3 and stage 4 lung cancer is easy to diagnose, but has a very high morbidity and mortality. However, the stage that we want to diagnose these patients, early stage, it's a lot more tricky to diagnose them, and we need really great navigational platforms to get down to these tiny lung nodules to biopsy them. And our goal ultimately is to stage shift patients so that they have better outcomes long term. Here in Olympia, Washington, we reviewed our cases back in 2021 and realized that 1 in 3 patients who underwent bronchoscopy died within 12 months. Most of these patients, more than 50%, had late-stage cancer, and it was taking us 2 to 3 months from initial detection of the lung nodule until treatment. So we knew we needed to revitalize our lung nodule program, and there are basically 4 components to this. We can have the best technology with us, but we need to be able to detect the lung nodules, refer them for evaluation, acquire technology and skills to diagnose, and then build capacity. I just want to highlight the importance that this presentation is about the benefits of the technology, but it has to be embedded within a solid lung nodule program and robotic bronchoscopy program. In terms of implementing our strategy, within the first 6 months, we're able to shorten the diagnosis and treatment of lung cancer by 3 weeks. We're able to get to much smaller lung nodules. Previous to using our robotic platform, we only diagnosed 10 cases with our legacy platform. With robotic technology, within the first 6 months, we diagnosed 131 lung cancers. Our diagnostic yield shot up from 50% to 85% using the intermediate definition, similar to the one that they used with Memorial Sloan Kettering's publication in chest. And we're able to get to much smaller lung cancer nodules, measuring 8 millimeters. As a result, we're able to increase more early stage lung cancer. We increased it from 44% to 58%. And most of these cases were diagnosed with robotic bronchoscopy. And most importantly, we showed that those patients that we diagnosed in the first 6 months, all the bronchoscopies that we performed, only 1 in 5 died compared to 1 in 3. So we are very excited about the progress that we had made in the first 6 months. We are diagnosing our patients faster. They had fewer pneumothoraces, only 1 to 2% compared to 20% with interventional radiology. We diagnosed twice as many cancers as the previous year. We stage shifted our patients, and we decreased our 12-month mortality, and everyone benefited. Which begs the question, why are we talking about advanced imaging in this presentation? And the reason is that we were still having difficulty with facing the challenge of successfully biopsying small lung nodules, challenging lung nodules. And for example, here's a nodule sitting in the left lower lobe, right up against the pleural surface, very deep in a costophrenic angle. And this was a patient referred to us by interventional radiology because they were like, this is too challenging for us. We're not going to sample it. Could you guys have a look? And here we got the lung moving, the diaphragm going up and down. We're going to navigate to this tiny lesion, make sure we don't cause a pneumothorax, no bleeding. And at the same time, the patient's supine, so there's a lot of atelectasis happening. So we had to devise a strategy to get to that nodule successfully and guarantee our patients that we would do it every single time. And we realized that we needed to have both robotic bronchoscopy and integrate it with our mobile cone beam CT, which had augmented fluoroscopy. And in terms of the rationale, the reason that we went with mobile cone beam CT, there are a number of reasons. And when I tally them up, I was surprised at the number, but this is what we found. So we knew that we needed advanced imaging. And the reason we got the advanced imaging was to correct for CT to body divergence, which authors such as Pritchett and Badra and Rationale have shown that sometimes there's a 2 centimeter difference from where you think the nodule is to where it is, and you need to be able to adjust for that. We wanted it to integrate with robotic bronchoscopy, which GE is able to do. We have excellent imaging quality. We didn't have a lot of money available, especially from administrators. We didn't have the ability to go to a fixed system. We knew it had to be a mobile. And we actually didn't want to go to the hybrid OR because it wasn't a dedicated space for us. We wanted our own dedicated space where we could focus on just lung nodule patients and do our bronchoscopies and not have to share it with vascular surgery or IR, who the administrators favored at that time. We wanted a system that had a similar footprint to our current C-arm that would fit within our bronchoscopy suite. At our hospital, GE is our preferred hospital vendor, so it made a lot of sense, especially for our radiation technologists who had to be familiar with the different technologies in different suites. So the fact that they knew the system outlay for how to operate the GE machine helped a great deal. We did a demo and a trial with the GE OEC 3D, and it went fantastically well. We were able to get to a 6 millimeter lung nodule and biopsy it and show cancer. And what was the sweetener in the decision to go with the mobile cone beam CT was that GE HealthCare were offering augmented fluoroscopy. And for those not familiar with the technology, basically we would do a cone beam spin, and then on the 3 views, the axial, sagittal, and coronal, we would put these yellow crosshairs on the lesion of interest. And once we click the button, those crosshairs would turn green, and we would convert. When we switch back to fluoroscopy, we'll be able to see the nodule overlaid with our fluoroscopy. And obviously the nodule is a sphere, but projected on a 2D screen, it ends up looking like a circle, which is 2D. And you're able to tilt it at different fluoro angles to confirm that you're actually in the lesion. So we were excited about the ability to use this technology. especially since previous authors like Joe Cecilia and Hogarth and Badra had said that fluoroscopy is fantastic, and we were excited about the ability to use this technology. So did it work? So I told you earlier that we were using our legacy platform, which had a diagnostic yield of 50%. This was pre-2022. When we moved on to robotic bronchoscopy alone, using the strict definition, our yield increased to 75%, so which was fantastic. That's where we saw the benefit in those patients stage shifting. Once we added mobile cone beam CT and augmented fluoroscopy, you'll see that our yield increased even more, 85% and 92%, and that was statistically significant. And even when we analyzed just for the progression from robotic bronchoscopy to robotic bronchoscopy with mobile cone beam CT and augmented fluoroscopy, that was significant. For those who want to know about diagnostic accuracy, the 12-month follow-up or 6-month follow-up, it stayed pretty similar, again, statistically significant. And this was all using the ATSF strict diagnostic yield definition. And then for the diagnostic accuracy, we used the definition recently published in the New England Journal of Medicine. Now, the question that we asked ourselves is, we've seen an increase in diagnostic yield, but which nodules, which patients were we helping the most to increase the yield? So we looked at nodule location, upper lobe versus lower lobe, and nodule size. In this cohort, 60% went upper lobes, 40% in the lower lobes. And in terms of size, the majority were less than 15 millimeters in size. So let's look and see what happened. So here we have robotic bronchoscopy with mobile cone beam CT, and then augmented fluoroscopy added. And you'll see in the upper lobes, our yield stayed pretty solid, 80 to 90%. But the biggest bang for our buck came in those lower lobe lesions, where we've seen a lot of CT to body divergence, and our yield increased from 60%, 67% all the way up to 95%, statistically significant. When we looked next at lung nodule size, if the nodule was more than 15 millimeters, again, let's say pretty solid at above 80%, 81 to 97%. And it was in those lung nodules less than 15 millimeters where we saw an increase in diagnostic yield. Those lung nodules that we want to diagnose early, for early cancer diagnosis and best 5-year survival, increased from 67% to 90%. The question you may ask is, so well, if you subdivide it into lower lobes and 15 millimeters, upper lobe 15 millimeters, what do you find? And unsurprisingly, you'll see that a lower lobe lesion less than 15 millimeters increased the yield from 58% to 96%, from 70% to 80 to 92%, and then for the upper lobes, 88% to 100%. And now with this technology, no matter the size of the nodule, no matter the location of the nodule, we can guarantee a yield of more than 80%. Interestingly, the most challenging ones are the upper lobe, where you're making that turn, but it's also the sites where you tend to have chronic inflammation that resolves, which with the strict diagnostic yield definition will be considered non-diagnostic. So ultimately, our diagnostic yield improved with mobile cone beam CT and augmented fluoroscopy. But I want to give you, so that's the obvious data, very simple to display, but I want to add a bit more nuance to the interpretation, because there's a lot of stuff that we did along the way using this technology over 27 months. So we're here in terms of the timeline. We started in October 2022 and it goes until the end of December 2024. We used our shape sensing robotic bronchoscopy platform as well as our anesthesia protocol throughout. We used radial EVIS for the vast majority, but once we got cone beam CT, it didn't add much value, so we stopped using it routinely. We started using cryobiopsy in March of 2023. And then in terms of advanced imaging, started mobile cone beam CT in January of 2024. It was integrated in early June 2024, and then we got augmented fluoroscopy for the last 4 months. And what really changed in our practice using the advanced imaging was really paying attention to breath holes and positioning. So let me just explain that a little bit more. What we noticed was that when you send a patient to interventional radiology for a CT-guided lung biopsy, we usually think, the benefits of getting a CT-guided biopsy is that they're able to see the lesion. They can see it in real time or pretty close to real time, put their needle in and confirm tool-in lesion and get a biopsy. What's interesting about these pictures is that you'll see the radiologists never biopsy something that's down where there's a whole bunch of atelectasis. They position the patients so that they have no atelectasis. So here's a patient who's prone, here's a patient who's wedged, and you can see a whole bunch more atelectasis on the dependent areal less here. And they sometimes even do lateral B-cube. And the benefits of doing this would be, firstly, you aren't biopsying lung tissue because it's atelectasis, but also if there's accidentally some bleeding, the bleeding doesn't obscure your ability to biopsy the nodule. So moving on, when I reviewed the data, most of the patients in the cohort that underwent cone beam CT guided biopsy with the robotic bronchoscopy, most of them were wedged, but a small proportion of them, we actually ended up proning them. Subsequently, we've decreased the amount of proning, but the proning definitely helped, and we've got a publication or a presentation at AABIP that will share our findings about proning. In terms of how we prone, we basically just use a gel chest roll that you can find in any OR and just slip it under one of the sides of the patient. So in terms of, given the fact that this whole bunch of different things that we are doing, how did that affect our diagnostic yield? So our first 225 patients in 15 months, median nodule size 16 millimeters, diagnostic yield is 75%. Once we added mobile cone beam CT, despite the nodule size getting smaller to 12 millimeters, our diagnostic yield increased to 85%. And then even then, when we added augmented fluoroscopy, we're able to increase our diagnostic yield even further to 92%. And we'll definitely discuss this in the discussion portion, but one of the questions that is going to be asked, how is augmented fluoroscopy gaining this additional benefit? And it's basically due to the ability to make sure that you're at the right depth of your biopsy, and to make sure that when you flip your augmented your fluoro angle by 90 degrees, that you're confirming that you're still tool-in lesion. What is exciting about these findings was that we had a smaller nodule size, and we also had a lower malignancy prevalence, and we still had a higher diagnostic yield. And that's because we're able to get more specific benign diagnoses, such as hematomas or organizing pneumonia or necrotizing granulomatous inflammation. So really being able to make good use of the cryobiopsy by targeted imaging. In terms of the radiation dose, I'll go back one slide. In terms of pneumothoraces, it was less than 1% for each of these series. You may ask, why are you getting a pneumothorax in a patient using all this advanced technology? And that's because this nodule was actually sitting abutting the pleura. There was no other way to biopsy it. We explained to the patient, we're able to confirm a solitary pulmonary fibrosis, and the patient went home the next day with a diagnosis, and we're very relieved that they didn't have cancer. In terms of DAP dose per nodule, it ended up being 24 for the initial 8 months, and then for the remaining 4 months, 29. So pretty safe profile or a good radiation dose for the nodules that we were targeting. So at the beginning, I mentioned, there's this challenge that we face in successfully biopsying these tiny 7 millimeter lung nodules. And the truth is now, these are no longer challenging. In this case, the patient ended up having ampullary adenocarcinoma. This was a situation where we did proning, we used our anesthesia protocol, we navigated with our robotic bronchoscopy platform, we confirmed a tool-in lesion with mobile cone beam CT. While biopsying, we adjusted augmented fluoro or our angle on the fluoro machine to confirm that we still remain tool-in lesion, getting good eye biopsies, and we're able to confirm ampullary adenocarcinoma. Here's another case that we did in April of this year. Same patient having 2 nodules, one in the anterior region, one in the posterior, a 6 to 7 millimeter sitting right up against the pleura, confirming tool-in lesion there. This patient had oligometastatic esophageal cancer. And here's an example using the augmented fluoroscopy. And here's the size of our cryoprobe, 1.1 millimeters. So we can actually magnify and confirm that we are within 1.5 millimeters of our target area. We flip the angle to 90 degrees to confirm that on both views that our tool is where it needs to be, and we're able to confirm esophageal cancer. In the same patient, as I mentioned, there was a 4 millimeter lung nodule that we went ahead and sampled. This ended up being a fibroelastic scar, but here's the nodule, tool-in lesion confirmation, and again, able to magnify. So now we about 1 millimeter diagnostic precision to ensure that we can target those lesions. And as was said at one of the cone beam CT courses, I think Dr. Brian Schaller and their team, they emphasize this in every single case that they do. One view is no view. You need to have at least two views 90 degrees apart and confirm that you are where you said you would be. And this is enabling us to get to basically any lung nodule. And this allows us to make the statement that at this point in time, we can accurately and reliably biopsy almost any lung nodule using robotic bronchoscopy, mobile cone beam CT with augmented fluoroscopy. So at this time, I'll pause and I'm going to actually turn to Dr. Lee. And while we're chatting, please feel free to start adding questions to the chat, and they'll be forwarded to us and after we interview Dr. Lee. So Peter, maybe you could go ahead and share with us some background on your program and how you built it up.
Yeah, thanks, Dominique. That was a great presentation, and in a short amount of time, you helped a tremendous amount of people. And yeah, that's what I continue to echo with a lot of my colleagues and new adopters to robotic bronchoscopy. So definitely gives us the ability to reach out to more people in more cases. So like I mentioned before, I'm an interventional pulmonologist. I moved out here to the Pacific Northwest from Virginia back in September of 2022. I was recruited here to start a brand new interventional pulmonology program along with within the pulmonary critical care division in conjunction with our Night Cancer Center. So we started the IP program that launched in fall of 2022. I'm also the medical director of the incidental pulmonary nodule program, which did not exist here before. So that launched formally in July of 2023. Our ION program kicked off in late January of 2023, and then we eventually ended up adopting mobile cone beam, the OEC, GE OEC 3D in September of that same year. Kind of, I guess, sort of overlapping with your timeline at the same time. OHSU, to kind of give people a little glimpse into what we are, who are not familiar with the Pacific Northwest. It's a quaternary care center, about 570-ish beds. It's the only academic institution within Oregon, so we get a lot of referrals from a very, very large state with kind of spotty lung cancer care and nodule care throughout the state and even part of southern Washington. So that does cover a large area.
Okay, that's a great background. So let's get into, well, maybe I'll ask you first, like, why did you think you needed advanced imaging in addition to robotic bronchoscopy before we go into this question?
Yeah, so the promise of robotic bronchoscopy were definitely brought a lot of us forward from. I'm a prior Illumicite user, FluoroNav, and definitely shape sensing technology, especially, just kind of really pushed us forward into areas where case selection was no longer a thing for me anymore. I didn't look for the airway sign, big lesions, size criteria, all that stuff kind of went out the door. And much like your experience, you just became bolder at these very small lesions that nobody else in IR or your thoracic radiology division would ever want to try to go after. And if we didn't exist, thoracic surgery would be overloaded with diagnostic wedge biopsies, which is not a good programmatic indicator and outcome measure for them. So we felt that, number one, to get to where we needed to be, 2D fluoro wasn't going to cut it. Therapy and endoluminal therapies are kind of in the just kind of off to the horizon. So we knew that that's going to be kind of right around the corner. But also clinical trials are actually out where you need to inject tumors with chemotherapy drugs or immunomodulating drugs and so on and so forth. So we wanted to make sure that we had good imaging technology to permit accuracy.
Perfect. And then this is a question that people often ask, choosing mobile versus fixed. In our situation, we just didn't have the money. I couldn't go to the OR and say, I'd like to use your hybrid OR because vascular surgery were using it. what was the rationale, or how was the decision process for deciding that you would prefer mobile rather than fixed?
Yeah, very similar to your explanations too. I mean, money is always going to be a cost if your hospital didn't already invest in a fixed cone beam CT scanner room or hybrid room. It's going to be a hard sell for an interventional pulmonologist or advanced bronchoscopist to sort of make that case. But for us, when we launched our ION program or all of our interventional pulmonology cases, we didn't have an out of OR GA space that we can use, just didn't exist before. So we stage all of our procedures within the main operating room. Thoracic surgery was gracious to allow us to share some of their block time. We got more block time as a result of the volume and so on. But because we were tied to the operating room, we just needed to be mobile, right? Having shape sensing and robotic technologies, we didn't need to electromagnetically map the rooms anymore, which was already a benefit. But if we're going to be hopping from room to room, we just needed a mobile unit. So.
And then some folks, I mean, the question sometimes comes in digital tomo versus a mobile cone beam CT, and there's some arguments made about the cost difference. How are you able to motivate to your administration that the mobile would generate sufficient revenue?
Yeah, we looked at the current state of lung cancer within the cancer registry at the Knight Cancer Center, and much like a lot of hospitals, there was a severe sharp dip in lung cancer registry numbers, which never really recovered. As we kind of came out of the pandemic, the numbers didn't really go up. Our tumor board typically saw a lot of kind of second, third line advanced cases, stage 3, stage 4s, and we just really needed a method to stage shift patients towards more surgical procedures, right? So more curative intent surgical procedures, even radiation cases where you can treat stage 1, have good long-term outcomes, and kind of reduce the burden on the healthcare system. As advanced bronchoscopists like us, our own presence and the fact that we are focused in this space already allows that, because we're passionate about this space and getting people in early. This is why I insisted on adding an incidental lung nodule program in addition to lung cancer screening. So it wasn't just about the technology alone, it was really the patient pathway from all different ways of detecting incidental nodules, from the emergency room trauma bays all the way up to lung cancer screening in the primary care physician's office. So the projected volume of all the cases that we might be losing out to, leaking out to the community, that in itself sort of made a case to invest in mobile cone beam CT technology, because that in itself, being able to contain all of these cases and being able to diagnose them and treat them here at OHSU would itself just generate and kind of pay for itself.
Okay, so to locking in that captive patient low incidental nodules. Mm-hmm. And then, so you've had the chance to use mobile cone beam CT, the GE OEC. So the question then is, how has it changed your practice? I mean, there's 3 components to it. There's the actual imaging, unintegrated. Then there's the integration portion, and then there's the augmented fluoroscopy. Maybe talk us through each of those 3.
Yeah, as far as intraprocedural imaging, well, first the OEC 3D, I don't know what they did with the 2D workflow, but the 2D, I'm sure you can attest to this yourself, but the 2D imaging was very, very sharp, very, very clear. I'm able to see tiny little skinny tools like our 1.1 millimeter cryo probe and skinny needles. I can even see fissures, interlobar fissures. So the 2D workflow alone just really improved our spatial awareness within the lungs. As far as 3D imaging, well, it really gives you a lot more confidence to go after these tough nodules like you were presenting, right? These little 7 millimeter things down at the gutters and the costophrenic angles right next to fissures, these really, really tough nodules. And these are not easy cases for really anybody, but really mobile cone beam gives you a lot more confidence to go after these. As far as integration goes, I like the integration because it helps you skip a step, because what you do and what a lot of people do after they spin, they see the CT, the reconstructed images in all 3 planes, and you're kind of going scrolling through. You're doing the mental geometry of where you are, where you should be, and all the little fine adjustments that you got to make, which, you know, you do it out of pattern recognition and just repetition. You know, it gets easier and easier after you do it for a while. But that integration with the Ion just really takes away that mental math entirely. So you just have it right there. You can focus on the ball, and then you throw in augmented fluoroscopy. Well, I mean, now that really ups your 2D workflow quite a bit, because you don't have the benefit of the reconstructed images in your face all the time. When you're throwing your tool out there, all you have is your 2D your 2D image. And so having that augmented fluoro target, just like you says, gives you that confidence of depth, right? That you should not go beyond this. And gone are the days of walking up to a C-arm tower with your Sharpie and just marking off the little distances. So kind of gives you that digital nice workflow that helps your 2D, and it helps me tighten up my cloud biopsies too.
Yeah, and I think what really impressed me was understanding that when you put your needle out of the robot, it comes straight out as it should. But when you put your forceps or even your cryoprobe, it kind of talks along the catheter. And if you put both tools out at the same depth, you'll find that there's actually a discrepancy sometimes with the needle point versus the cryoprobe point, just because it's had a slight curvature. And obviously, the further away from the nodule you are, the greater the curvature. So you can sometimes hit the nodule with your spin, and then when you put a different tool in, it's actually sitting adjacent to it. What has your experience been?
Yeah, it happens the most for extraluminal lesions, right? Where you just got to get the right amount of tenting and the right angle before you kind of punch through. And yeah, with the blunted tool of a cryoprobe, it's just going to follow that airway sometimes, and the needle may go through, may graze a little bit. So yeah, you get a lot of kind of bending of the tool. But with augmented fluoro, it helps you kind of angle the tip of the catheter a little bit more right into the lesion. So yeah, go ahead. No, and it's a lot of these part solid nodules, right? Which is when you're running a lung nodule program, you're going to see a lot of these things. You cannot see them on any 2D workflow. So this is where where augmented fluoro really shines.
Yeah, and I've also found, like, sometimes if you're doing an upper lobe lesion, especially if it's a medial upper lobe, right upper lobe, you curl your catheter around and then your needle will come straight out. But then when you take your cryoprobe actually follows the curvature of the catheter. So when it comes out, the needle comes out like that, but the cryoprobe is still following the curvature of the catheter, and it actually comes and ends up doing that. So making sure that you make that adjustment appropriately, the only way that you can really do that is having that augmented fluoroscopy ball, which is...
Yeah, the cryoprobe, strangely, I don't know if it's the heating and like the warming, cooling cycle, the metal inside just starts to develop a brand new memory.
Yeah, it does that. So it's great to ensure, especially if you want those good biopsies. You wanted to talk about how the advanced imaging made you really focus on breath holds. Maybe talk us through your experience.
Yeah, so breath holds, this is part of our learning curve, right? So I think there's no standard to how people do breath holds. I think I've heard many different varieties of how breath holds are done. Prior to adopting ion and shape sensing with electromagnetic navigation and fluoronav, what we used before, the breath hold would be basically asking the anesthesiologist to look at their pressure tracing, give some back pressure or just set their APL valve and just make sure that we have a consistent pressure, not knowing what's dynamically happening inside the lungs, right? So you flip an APL valve, you might get the most perfect pressure tracing, the most perfect plateau, but at the same time, your lungs are dynamically deflating. If it's too much pressure, you may overinflate, and that you're prone to CT body divergence while you're doing the imaging. So what we noticed was that when in our first few cases with mobile cone beam, there was a good amount of atelectasis, but we, understanding Roberto Casal's work down in Texas, understanding the dynamic atelectasis that you see. I think that's one of the first lessons we as a community learned, is the benefit of PEEP. Okay, so dialed up the PEEP, generally use anywhere between 12 to 15 of PEEP at the beginning of the case. During the initial flexible bronchoscopy sort of airway review and suctioning and everything, I just assume that I'm causing any movement within and any suctioning would just reduce your alveolar volume and promote atelectasis. So before I do any navigation or registration, I always have the anesthesiologist give me a couple of recruitment breaths, right? So just kind of match the PEEP, re-recruit, and then the PEEP definitely helped eliminate a lot of the atelectasis that would happen, right? So on top of that, just to make sure that there's not a whole lot of catheter movement, right? So catheter and target movement, just to make sure that we're aligned. I opt for a lower tidal volume type strategy. You know, some people do higher tidal volume and so on, but I'm trying to mimic the conditions where you would actually have a breath hold where the catheter would really not move, much at all. So we start off at 6 cc's per kg, okay, with a PEEP of either between 12 to 15, depending on the body habitus. And for those of us who did critical care, I mean, this is your basic ARDS strategy, right? So if the sickest of the sick can tolerate it, you've got pre-selected, patients under general anesthesia can tolerate it even better. So that's what we opt for. And if there's still a lot of catheter movement, which I typically see in the right middle lobe or the lingula or at the bases, I have the anesthesiologist incrementally drop the tidal volume by 50 cc's each until I can see just a little bit of bobbing, okay, maybe within a catheter width. I always do a test breath hold while our C-arm tech is doing the sweep and collision checks and all that stuff. So I just have them do a test breath hold where I tell them to pick a pressure on the APL valve. I use the catheter reference tool, which is probably unique to the Ion system. And I tell the anesthesiologist, well, regardless of what pressure you're using, don't focus on the pressure or tracing the pressure curve. Look at my catheter reference tool. And we want the green catheter and the gray catheter. For those of you who are Ion users out there, you know what I'm talking about. We want the two catheters aligned, because if they use an insufficient amount of pressure, we see the catheters diverging quite a bit. They give a little bit more bag pressure, and all of a sudden the catheters kind of come back in line. And I tell them, this is what I want during the spin. And that pretty much guaranteed us at least, nice crisp images. Even I don't routinely prone or wedge anybody, but we still get pretty good images with very minimal or to no atelectasis in our patients.
Yeah, and this picture for the audience, I mean, this is the same patient. One's with the patient lightly breathing or not perfectly, as you said, things matching up, and the detailing quality is quite staggering. So really making sure that you pay attention to the basics, anesthesia protocol and breath holds when indicated. I wanted to show this because I think this was, for me, blew my mind. For example, here's a patient who created, here's a nodule over here. I put my tool out and it's about to touch the nodule, but then I go ahead and do a 90-degree spin with my fluoro, and guess what? I'm missing it completely because I'm actually to the side of it. So this is where it becomes really important when using augmented fluoroscopy to make the adjustment. So again, I made the slight adjustment with my catheter so that the needle is touching the augmented fluoro ball, and then confirming again on the previous view that I'm still within the tool. And you can see it actually moves slightly a bit. So it's a back and forth. And again, as I said, with the Cone Beam CT course at Stanford, making sure one view is no view. You've got to check both views at 90-degree angles to confirm that you're still two in lesion. So how was your transition to advanced imaging? So I mean, this is the question that people ask, how much of a learning curve is there? What do you have to know about radiation dose, getting a workflow together? Tell us about your experience. How challenging was it? How long was your learning phase?
Yeah, the learning curve wasn't too bad. If you're coming from an environment where you heavily use 2D fluoro and radial EBUS for a long time, and you have a good idea of spatial recognition in the airways, the adoption to cone beam wasn't too bad. For our whole team, it wasn't bad at all. Our C-arm techs, they're familiar with GE advanced imaging and C-arm mobile units all over our hospital, so they picked up on the OEC 3D pretty quickly. So it was easy for me to communicate verbally what I need, and they could just navigate everything on the touch screen there and kind of give me what I need. So that learning curve was super easy. The biggest thing that I learned again was optimizing the quality of your image, and I think this is one of the stumbling blocks that a lot of people have, is they spin, not really cognizant of a breath hold or a PEEP or atelectasis or anything like that, and then you end up with a suboptimal image, and you can in some you would develop mistrust of the technology, but really isn't the technology, it's just you need to optimize the conditions of a nicely inflated lungs, because the patient who did their reference CT scan for your planning CT, they had their arms in the air, took a deep breath, held it for a few seconds, right? And you get nice crisp images on a CT scanner. So we wanted to sort of mimic that. And it took a lot of conversations with very thoughtful anesthesiologists here about what I need and how their pressures are affecting my imaging. And a lot of our anesthesiologists work in the ICU, so that sort of transference of what I need and what they can do was really easy. So we kind of spoke the same language. But also learning what kind of nodules that you need to spin for, or at least I needed to spin for, right? These are the ones just like you're in your slides, the ones that are very close to the pleura, close to the diaphragm, down in the costophrenic angles, the ones that are right smack, just laying right on top of the oblique and major fissures. Those are really tough to go after, because you never really know what angle your needle is going into when your fissure is kind of going in this, and it's you need to be cognizant of the three-dimensional nature of all the fissures, the intralobar fissures. Part solid lesions, right? So these are with small little 6 millimeter solid components. You're not going to see those on 2D fluoro. So those are quite tough to go after. So we using cone beam CT and augmented fluoro, those kind of give you a lot more confidence as to where you're throwing your needle. But yeah, the learning curve was basically that. As far as dose reduction goes, we use a low dose setting on our GE machine, and the numbers aren't too far from what you had shown, right? But understanding which nodules that I'm more likely to spin, I usually kind of have an idea when I'm planning the case whether I need to spin or not. Last I checked, I think I'm spinning about 40 to 45% of my cases, and the rest I'm kind of trusting the planning software and 2D fluoro and solid 15, 17 millimeter nodule out in the upper lobes are pretty easy to see on 2D fluoro, so I don't need to spin for those. I still use radial EBUS. I know it's sort of controversial whether it's still needed nowadays or not, but I'm still very heavily reliant on it. That's how I was trained. But as many confirmatory tools at your disposal, that just leads to success.
Yeah, I think it's interesting because there's definitely different personalities, and some folks, as you said, spin 10%, 40% of the time. Other folks spin every time. I personally, I want to confirm I'm tooling lesion in everything, and I use it because not only to confirm that I'm in tooling lesion, but when I'm doing that cloud biopsy around it, I want to make sure every single sample that I'm getting is tissue, not lung tissue. And this obviously a different way of doing it, and we're going to have to figure out what is the best way. But until we do what's best for your patient and what you think is going to get you the best result.
That's right.
How have you addressed radiation safety? You mentioned that the GE allows you the function of dose reduction. What other measures have you taken? Because this seems to be a hotly contested issue or big issue put forward as to why folks should be cautious about cone beam CT. So maybe are you leaving the room? Obviously, you wearing lead glasses. What other things are you doing to make sure that it's safe for the patient and safe for you?
Yeah, we don't typically leave the room for the mobile spin cases. We stay probably at least 6 feet away, and as far as the anesthesiologists who need to be there, sort of doing the breath hold, we do have a lead barrier that we wheel in from different part of the OR, just to kind of put right in front of them, because they're the ones literally within a few feet of the C-arm. Other dose reduction strategies kind of come from 2D fluoro, right? So shooting when you're about to put the needle out, avoiding long exposure times. Like I mentioned, the low dose setting on the OEC 3D is a really nice way to just make guarantee. They also have HD settings as well, which kind of accentuate hard borders of metallic bony objects and things like that. So those are nice ways. Also, the biggest thing is, I mean, for me personally, and this is really at the discretion of the user, is to understand which nodules I want to spin for. So I don't spin for every single one, but that helps kind of reduce the amount of radiation exposure. But yeah, we're going to be working with GE shortly on looking at our case data, and since I'm the only one that uses our mobile cone beam unit, they're going to help us sort of analyze all of our cases, how often that we're spinning, the dose strategies based on BMI and so on.
Perfect. And then we tend to leave the room every single time, no issues that we've had in that regard. And then what we've done is also mark all our tools, so we know at a certain depth is when the tool is within a centimeter or so of exiting. So we just mark it there, and that way when we're touching the pedal, it's only when it's within a centimeter of coming out. So that helps. Because I think folks have shown that your largest radiation dose is sometimes not from the cone beam CT. If you're leaving the room, it's actually the fluoro time that you're doing.
Yep.
And then you've said that 40% of the time you spin, 60% of the time you don't spin. So which nodules are you not targeting, or is it size dependent, location dependent? What's your strategy?
Yeah, the nodules that are away from fissures, a little bit more central within the parenchyma, obvious airway sign on planning CT scans. These have obvious airways that lead in there, and I tend, we tend to get a pretty good radial signal on these types of lesions, and definitely size, right? The larger the size, for me, don't really need to spin for the larger ones where I know I'm gonna go after, I'm gonna get them. This is, again, like, it really reduced, case time and how many times we spin and so on. But you can kind of tell from the original planning CT scan whether so that's been my criteria as far as when to spin and not to spin. But I've been fooled where I think it's going to be a softball, and all of a sudden I get out there, and for some reason, whether there's CT body divergence or some computer generated error shows up where I'm like, okay, well, I thought I was going to be there, right? Now I can't see it. Or if it's an extraluminal lesion, and I'm not quite sure, and I know I might be near vascular structures, then I'll spin if I'm just not able to see it under radial EBUS.
So I mean, so the pushback on that is going to be, we know that if, let's say, accidentally there is, some CT to body divergence, or there's some bleeding, I mean, that's the commonest reason for a non-diagnostic result. We're putting the patient through at least a $6,000 procedure, $60,000 built to insurance. What would your response be if folks said, well, you got the technology, let's use it? And I'm playing devil's advocate here, so.
Right, no, understood. No, I've been asked that question a lot too. I would say it comes down to the user and your experience level and how comfortable you are in terms of your spatial awareness and how much you trust the software. If it makes sense for your workflow to guarantee that you have your catheter in place and it's facing the nodule every single time, then if that helps your diagnostic yield, then utilize the tool. And again, the radiation dosage with each cone beam spin really isn't that great. I myself I haven't really run into those types of situations where I think I'm going to get it with these typical very large grapefruit type lesions, the softballs, and then I've come and find out that, oh gosh, I need to spin. It's not often. It's once in a blue moon, But yeah, but this is why I'm happy that we have the technology. I can use it whenever I need to and not use it. So yeah.
What about these patients with large BMIs? And I've got a case, two cases here, and there's some folks who are like, well, can we do these with mobile cone beam CT? And here's two cases, one with a BMI 54, 335 pounds, right lower lobe lesion, sitting in that, really tricky area, high risk of atelectasis. And this one we ended up proning a confirmed two lesion. Got metastatic renal cancer. Here's another one, BMI 50. Again, in this case, prone, got a diagnosis of a hematoma. We sampled it because it was enlarging in size. How are you managing these patients? Because it seems as though these are becoming a bit more frequent. We get these high BMI, more than 40. How are you approaching them? How has the technology helped? Any limitations?
Yeah. BMI of 50, yeah, I'm seeing more and more of those. They're tough, and it really depends on their body habits. If they're more kind of pear-shaped and their shoulders are actually kind of lean, they're okay, but if they're a little bit more apple-shaped and their shoulders are kind of, falling off the bed and everything, that makes it a little challenging. Where we've had some success is we'll take their shoulders and their arms and kind of cross them in front of the body and sort of papoose them, right? So we'll take the big draw sheet. The nurses in the OR are fantastic at this. They'll take the draw sheet, really crimp it really tight using some clips, anteriorly. We will shift the patient where the patient's not centered on the bed, but the nodule is as centered as possible on the bed, right? So if it's a lateral right upper lobe lesion, we'll shift them leftwards on the table as much as possible. There are plastic sleds that we can utilize from the OR. We just slide them underneath the upper arms and try to make them as compact as possible. It's really the lateral size, not the AP dimensions, that really kind of limit how well you can spin from a mobile cone beam unit. And it's always bumping the shoulders, and the toughest lesions, I will say, are the most lateral lesions. Okay, the ones that are way out on the sides, because you're trying to shift the patient over, but because of their body habitus, you can't get them as far as possible, so you're just kind of stuck in the middle of the table. And for the cone beam to be able to capture that lung that's way on the edge of your right upper lobe, right middle lobe, or wherever, they need to shift the C-arm over a little bit, right? And which also limits you on the other side. So you're kind of kind of trying to steal some space on this side, but you kind of hurt yourself on the other side. These cases have been kind of challenging. And to your credit, and you've advised me on this, I'm looking at trying to maybe put a little wedge, because if the AP diameter is less of an issue, then maybe just kind of rotating them around.
Yeah, I've been amazed, especially some of the patients with the big, you just put a wedge there and it actually lifts everything, gets rid of the atelectasis, and it actually pushes the nodule. Instead of it sitting over here, it ends up going a bit more that way. So it actually moves more medially and more apical, well, anteriorly, so you end up with less atelectasis. And then I think one of the features with the cone beam CT now is that you don't have to do a full 200 spin. You can do 80%, so 160 degrees. So that's another way that you can get around that. And then last question for you before we turn to the audience. Which improvements would you like to see? So you've obviously been able to pilot one of these really great innovative technologies, both integrated cone beam CT and augmented fluoroscopy. What would you like to see going forward to address any of the concerns that you have?
Yeah, I would love to see, as the market for mobile cone beam CTs continue to widen and it's becoming more and more accessible to people who don't have the luxury of a fixed cone beam system, it would be nice to see the gap between the two technologies start to kind of narrow, okay, in terms of the time to spin, right? A mobile cone beam spin is about 30 seconds, right? I think that's the same for its competitors, but a fixed cone beam system, if anyone's ever seen it, boy, it is fast. It is really cool, and it's really easy to be able to spin in 5-6 seconds and do it over and over again. And it's nice to have. So maybe a faster spin the ability to segment the nodule rather than a green ball, to segment the nodule in its true shape with maybe airway segmentation that kind of leads to it. So it gives you a little bit more, you're taking your 2D images and making them a little bit more dynamic.
At this time, I'm going to open up I think that's, that's the last question. So I'm going to open it up to the floor now and see if any questions have come in. One of the questions that we definitely want to address is, you mentioned the importance of collaborating with the anesthesiologist, and it seems as though there's just way more people in the bronchoscopy suite these days. You got your anesthesiologist, you got your rad tech, you got your nurse, you got your RT or endo tech, there's yourself, some people have trainees. How are you coordinating and working with your team so that everyone's on the same page and focused on getting the job done? Maybe talk us through a bit about that.
Yeah, I think the number one thing, and I'm sure you can attest to this, is having the luxury of having the same team over and over again. In the OR, we have the benefit of 4 nurses who've been trained on the Ion and our mobile cone beam, so they know our workflows. I have 2 respiratory therapists who are amazing and who are just dedicated to interventional pulmonology procedures. As far as the anesthesiologists go, I seem to see the regular cast of characters in terms of CRNAs and anesthesiologists. So having the same team enhances your predictive potential. That's number one. That's sort of the unspoken dynamic of team building. Before we go into a case in the pre-op area, I usually run into either the anesthesiologist or the CRNA or the resident, and we just do a very quick 10-15 second huddle about what I'm doing, okay, and what type of airway we need, and the sedation strategies, how long we think we need sedation, and whether we need paralysis or not, which generally, we always paralyze all of our cases. So a very brief huddle, and then I kind of give them a snapshot of the day ahead. So if I have 4 ions, I let them know, yes, we're going to do this, and just repeat what we're going to do for the rest of the day. So clear communication. So that's been beneficial.
Okay, a couple more questions here. So next question is, how much time is 3D adding to your, okay, so that's a question. So is it adding to your cases? Yes, no, or is it shortening your cases? And I guess, what is the learning curve when you start using it? How much extra time does it add? Are you able to make that time back up as time goes along? Or do you even become faster as you're using the technology?
We've gotten faster. I think early on, we got ourselves into a bit of a jam when we would spin, do some biopsies, our on-site pathology wouldn't give us an answer, then we would spin again, find blood and atelectasis, and so each successive spin after you do your intervention, just the image just gets worse and worse. Just like radial EBUS, your image will get worse and worse as time goes on. Pre-selecting cases, spinning earlier in the case before you've done any sort of intervention, that has definitely helped reduce the amount of spins that I do. If I do spin for a case, it's usually once, maybe twice, and that it's just more for confirmation. Okay, and I will, if I do repeat a spin, it's because I'm going to another lobe or I'm going to the other side, right? Just to tackle multiple nodules. But I feel like it really hasn't hampered my workflow. Even with that addition, the Ion robotic case times are actually just going down. We're getting to cases and staging their mediastinum faster and faster, all within an hour now. I think the benefit of having a 3D imaging, intraprocedural 3D imaging, just really gives you that confidence to kind of stay on target, now I have more trust in the virtual target that I have, right? Especially with integration and augmented fluoro. So I don't frequently need to respin. So.
Gotcha. And then I just wanted to show you, so I had a period of time where I didn't have any integration, it was unintegrated. So as you said, that mental map, and I realized that I needed to do a little bit of, positioning to move the nodule to a better location. And this is the crazy algorithm I came up with to make sure. And it actually ended up showing that our yield with integration versus non-integration ended up being the same. But it was painful. It was torture. And I was so happy when the integration came out. And as you said, we've actually found that adding the augmented fluoro as well, the time of our procedures didn't change, but what we actually found was that I'm actually doing more nodules in the case than I was before. So when I looked at my initial cases, I was doing just 1 nodule per case. It ended up going up to 1.2, and now I can do up to 4 nodules. It'll probably take 120 minutes, and that's from the time the patient enters the room until the next patient can enter the room. That's not the bronchoscopy time; it's the in-suite duration. But the technology with time does help you to actually speed up the cases. I got another question here, and I'll try and keep it as generic as possible. So there are folks who are looking to get technology, whether it's a robotic technology, whether it's getting advanced imaging, mobile cone beam CT. What advice would you give them on, I mean, you obviously have gone with ION and GE. What is the rationale for that, and what advice would you give them in making the decision so that long-term it benefits them in their program?
Boy, that's a very tough question.
Yeah. That's why they're pretty big bucks, man.
Yeah. It's a tough question and not so tough. Yeah, you walk into a convention hall and you are bombarded with lots of tech, right? Lots of different imaging modalities, lots of sales pitches. I'll say that it really comes down to just having a deep understanding of a technology and what it can do, right? Outside of a conventional hall, outside of a demo, outside of just a little plastic lung nodule, lung model, right? I really encourage people to go to these centers that have these different types of technologies and go observe a case. Go see and talk to people. It's really, a lot of it is word of mouth and what people really advocate. You'll see a lot of marketing data one way or another. You talk to different companies and they'll tell you, their side of the marketing data and how they interpret each facet of that very complex puzzle. But it really comes down to what you're trying to achieve. The budget of your hospital, of course, what they're willing to do, the volume, is it really worth it? Is there an ROI behind it? And I will say that, and of course, we're biased, right? We're both, you and I are both ION users. I put a lot of emphasis on the planning software, all right, the brains of the system, the planning, the part that you don't get to see during a demo or a live case demonstration is how a user sits down in their office or in the suite just to plan out the cases, and the algorithms that are baked into different planning softwares from different companies really make a difference in terms of how successful you're going to be in terms of minimizing CT body divergence and so on and so forth. So it's not just one piece of technology. It's case selection, the brains behind that planning software, that laptop that they give you, the optimal conditions in the operating room, the ventilator strategies, the cone beam, what advanced imaging tool you're using, whether you're an adopter or you still current user of radial EBUS or not. All of this sort of adds up. In my opinion, it adds up to your success.
Yeah, I think a lot of times we see these features, it's this feature, that feature, and I think what we need to ask ourselves, what happens when it hits the road? Like, yes, you're telling me that this does X, Y, and Z, but can it guarantee me diagnostic yield? Don't tell me that it can do this and do that. And then also looking at the longevity of the company, making sure that the technology that you're going to use today is going to be there in a year's time, and that they're constantly innovating. I think one of the things that really impressed me about both Intuitive and for GE is that every couple of months or every 6 months, there's something new that's coming out. If I was advising someone, I would say, pay attention to who's constantly innovating, who's addressing your need, and actually, when you use the technology, you get the yield that you want so that you can impact the patients. Any closing words, Peter, before we sign off?
Well, no, I really appreciate, this is a fun conversation. I love chatting with you, even offline. You and I chat quite a bit, and this was a lot of fun to kind of talk shop with people who were, you know, behind this science. And I love talking nodules and technology. I think in the past decade, lung nodules, as a pulmonary fellow, no one cared about lung nodules. You know, no one even wanted to bother with it. But now all of a sudden, this little thing that we ignored, you know, as early fellows and early trainees, it's becoming like the focal point of our programs here, and we're able to make a huge difference even with the tiniest nodules. So I just urge everyone to, regardless of what technology you want to use, put the patient first, put the needs of the patient and where they are in their lives and why they need this diagnosis so bad. Just put their sort of livelihood, you know, at the forefront. You always come second, right? But a close second. I mean, we need to be happy, very confident proceduralists to be able to serve the people that we serve. So, you know, trust in that. You know, let that be your North Star, and then all the other technologies, everything else that you adopt, you know, that all just kind of falls into place.
Exactly. I mean, lung cancer is still the #1 cancer killer, and we need to address it. And a very big thank you to GE HealthCare for sponsoring this webinar for the Society of Advanced Bronchoscopy. An absolute pleasure chatting with you, Peter. You take care.
You too. Take care.
Goodbye.